You are here to hear from Dr. Albert Farrow. He is Senior Director of Clinical Affairs at the CF Foundation. Unfortunately, due to weather, Dr. Farrow could not make it here, so we have him virtually, and I'm sure that you're going to enjoy the presentation that he has today. So Dr. Farrow, I turn the program over to you.
Thank you, Paul. I appreciate it. And thank you for those in attendance and taking a chance on this sort of virtual presentation. I'm really sorry that I can't be there today. I wish I could have made it. But through the miracles of technology, we'll be able to proceed with the presentation. So next slide, please. Oh, I do need to take care of a little business, which is we'll be taking questions at the end of this presentation using an easy online platform. Whether you're here with us, well, whether you're there in Dallas or you're at home like I am, you can submit questions for us through your phone, laptop, or tablet. Just open your browser and type in cff.cnf.io. Again, that's cff.cnf.io. Click on the name of this session, then submit your questions in real time, and we'll do our best to answer as many questions as possible at the end of the session. Next slide, please. So just a little context about myself. I'm a pediatric pulmonologist by training. I joined the foundation just this August. My clinical expertise has been focused on cystic fibrosis and children receiving lung transplants. And again, I've been taking care of children who've undergone lung transplantation for the last 20 years. Now, what I want to start with is providing you some context about what the transplant journey looks like. And then finish with just giving you a little sense of what the CF Foundation is taking on, the initiative it's taking on to try and improve that journey. So the first question we must always ask ourselves as we start pursuing the transplant journey is transplant the right treatment for me? And not only does the person with CF thinking about lung transplant need to think about that, but certainly so does the transplant team. Because the best analogy I can give you is in terms of a treatment would be if you were having pain right now from a headache, taking an aspirin might be a very, very appropriate treatment option. However, if your pain is coming from a knife wound and you're bleeding, well then aspirin is probably not the best treatment choice. So just in that fashion, we have to determine whether or not lung transplantation is an appropriate treatment. And that's on multiple levels. First and foremost, for the well-being of the person undergoing the transplant evaluation to be sure that this is right for them, but also understanding that donor lungs remain a very precious and scarce resource. Approximately 16% of patients who are on the wait list die on the wait list. There are not enough donor organs to go around for everybody on the transplant list. So it's very important that we are transplanting people who would benefit from the procedure, not people for whom the treatment choice is not the right one. Now, this kind of brings us to the evaluation, because how do you determine if it's the right treatment or not? And it's by undergoing an evaluation. And I know the evaluation is anxiety-provoking, causes much angst and sometimes frustration, but it is not a report card, and it's most certainly not punitive. It's not a way to find, the evaluation itself is not a way to find things to find that will keep someone off of the transplant list. In fact, it allows the transplant team to find potential problems early, before the surgery, so that they can address these problems and make a difference and improve the outcome rather than be surprised later in the intensive care unit by something they were not aware of. So it's certainly not punitive. And as I always used to tell people when I met them for the first time for their initial transplant evaluation, just as much as the transplant center is evaluating whether or not transplantation is the right treatment, they should be evaluating the transplant center and determining if it's a right fit for them, if they feel comfortable there, if they feel that the expertise is there. So the evaluation is very much bilateral. Now, I understand that sometimes for certain insurances, there may be limitations. But for many people, there are options, and you're not necessarily tied to one transplant center. Now, the contraindications that might be discovered during a transplant evaluation that may prevent transplant from occurring are evidence-based and experience-based. They're not things that people have pulled out of a hat. They're known to portend a poorer outcome for people if they have those contraindications in place. Next slide, please. So this is sort of an example of potential absolute and relative contraindications. And what do I mean by that? Well, absolute contraindications are those that a center has determined that if a potential transplant recipient has, they would not put them on the transplant list. A very important subject matter for people with cystic fibrosis considering lung transplant is going to be the types of germs or bacteria that are chronically infecting their airway. So for instance, if a patient with CF has Burkholderia stenocepacia chronically infecting their airway, we know from studies that that portends a very, very poor outcome after transplant. In point of fact, the published literature would suggest anywhere from a 30 to 40% one-year survival after transplant for people with cystic fibrosis who are chronically infected with stenocepacia. This is very important too because there are many different species in the Burkholderia cepacia complex. So you can have, for say, Burkholderia multiborans, and most centers won't blink at that and will be fine transplanting this patient with Burkholderia multiborans, assuming everything else is okay. But it is stenocepacia that we're talking about. And that's because the outcomes have been shown to be poor, so transplant centers, in many cases, will view that as an absolute contraindication. A relative contraindication is one that we're glad that we know about because we can prepare for it prior to the transplant and be ready at the time of transplant to address this relative contraindication and hopefully lead to a better outcome. And so those relative contraindications, unless there are many relative contraindications, will not pose as a barrier to proceeding with transplant. Next slide, please. So, assuming the evaluation has gone well, and the transplant center feels that the person who's come for the evaluation is an appropriate candidate, and very importantly, the person who's had the lung transplant evaluation feels that they wish to continue on this path and pursue a lung transplant, when is the right time to have the transplant done? And we're sort of fortunate in the CF community in that we have many, many studies to try and help us predict what is the right time as compared to many other of the disease states that lead to lung transplantation. Unfortunately, despite all the data, the truth is that we still don't have clear-cut, objective guideposts to tell us, aha, now is the time. One of the initial roadmaps that we had came from Dr. Karen, who was at the University of Toronto at the time, that he did this study trying to predict mortality in his patients with cystic fibrosis. And he determined that an FEV1, so lung function, less than 30% predicted, combined with a certain oxygen level and carbon dioxide level in the blood, were predictive of 50% two-year mortality. And the lung transplant community quickly adopted that as a guidepost to help determine when would be the right time to list a person with cystic fibrosis on the list. Shortly thereafter, the team in Cleveland said, whoa, wait a second. We just did the same study using Karam's criteria and discovered that a quarter of our patients who met those criteria were still alive 10 years after meeting those criteria. So after that, many more models were developed that were much more complex, included many more variables, weighted them differently, and there are a lot of really nice papers looking at trying to predict mortality in cystic fibrosis. But the truth is, at the end of the day, when compared to Karam's criteria, they're no better at predicting. So for better or worse, we still live around this FEV1 of 30% predicted. And I know it causes a lot of angst within the CF community, as well as among CF physicians. We all get focused on this FEV1 of 30% predicted. But the truth is, there's very little sensitivity and very little specificity to that sole number. So clinicians in the transplant field tend to look beyond that and use their clinical gestalt and look at other things such as increasing frequency of hospital admissions, deteriorating functional status, the need for things such as a BiPAP machine or a CPAP machine, need for supplemental oxygen, importantly, having those hospital admissions, but then the FEV1 not improving, no improvement after hospital admissions, and pulmonary hypertension. So that's high blood pressure in the lungs. And those tend to be signals for clinicians in the CF world as well in the lung transplant world to say that maybe now is the right time to proceed. Next slide, please. So how is position on the wait list determined? Prior to 2005, it was purely based on time on the list. So it wasn't the sickest person on the list who got the offer of a donor organ, but rather the person who had the most time spent on the list. In 2005, the lung allocation score was developed. A lot of people spent a lot of time working on trying to predict wait list mortality. So in other words, the risk of dying on the wait list, to then provide people with a higher risk of dying on the wait list a higher score, moving them up on the transplant list. But also what the lung allocation score does, which no organ at that time did, was also account for survival benefit. So in other words, it would make sense to try and allocate organs to those people who would derive the most benefit from receiving those organs. But still, the lung allocation score is heavily weighted to transplant urgency. In other words, the score provides more weight to the sickest person on the list as compared to anything else. And it includes all these different variables, which I'm really not going to go into at this point, but I'm happy to answer questions about them later. But clearly look at lung function as well as how other organs are functioning. Next slide, please. So what does the wait list look like? There are approximately 2,500 people added to the lung transplant list every year. That's a lot. Now, there are 2,500 people on the list at any given time. There are 1,600 people active on the list at any given time because there are people that are being transplanted, there are people who do die on the list, and there are people who are taken off the list, sometimes because they're doing well and don't need to be on the list at that point. Approximately 12% of the people on the lung transplant wait list in the United States have cystic fibrosis. So we're a small minority of the number of people waiting for a lung transplant. Now, in 2016, and so this is really hot off the presses, the number of lung transplants performed in the U.S. actually went up by about 250. So we did see a small increase in the number of transplants. The overall median months to transplant. Now, remember, what median means is that 50% of people on the list by that time have received a transplant, 50% have not. So the overall median number of months is 3.4 months. That's for everybody on the lung transplant wait list. For people with CF waiting for a lung transplant, it's a little bit longer at 4 months. So again, 50% of people with CF who are on the wait list are transplanted within 4 months of being put on the list. Unfortunately, the waitlist mortality for people with CF is actually higher than it is for the general population waiting for a lung transplant. Remember, I mentioned it was 16% for the anybody on the waitlist. For people with CF, it's 21%. So it is higher. Next slide, please. Now, assuming everything has gone well, you're on the lung transplant waitlist, and now you have the highest lung allocation score. Will you be the one to get those lungs that become available? And the answer is maybe, because there are still some other variables that have to be taken into account. So one is size, and there you see a picture of Shaq with Earl Boykin, and these are two basketball players, but still you can see there's a tremendous difference in height between the two of them. So if Earl decided to be a lung donor and his lungs became available, despite the fact that Shaq might be number one on the lung allocation list, he will not get Earl's lungs because they're too small. They won't function well inside of Shaq's chest. And vice versa. If Earl's waiting for lungs and Shaq is the donor, Shaq's lungs won't be going to Earl because they're too big and would require too much tailoring. Sometimes surgeons are happy to staple some portions of lung off, but this would be too much and would probably lead to complications after the procedure. So size does matter. No matter what you've ever heard in the past, size does matter. The other is blood type. So let's say you're the right size, you're number one on the list, yet you're an A blood type and the donor is a B blood type. Those lungs aren't coming to you because we don't transplant across blood types. That would lead to immediate hyperacute rejection. So your donor, if you're an A, your donor needs to be an A or an O, but it can't be a B. And then, lastly, is the region you're in. So lungs are dispersed regionally, and there is somewhat good reason for that. They're dispersed in 500-mile radii because there is something called the ischemic time. And for lungs, that means from the moment the team that has gone out to harvest the lungs have taken the lungs out of the chest and put them in that cooler and have started their trip back to the transplant center, the clock starts ticking. And until they're sewn into the recipient and the blood is being perfused into those lungs, that time is what is called the ischemic time. And we don't want those times to be too long because they can lead to complications. So for instance, if the potential recipient is in Miami and the donor is in Seattle, those donor lungs, despite the fact that the person in Miami may have the highest lung allocation score, be the right size and be the right blood type, will not be going to the person in Miami because it is just too far and the ischemic time is going to be too long. Now, there are issues with this regional system that actually probably prevent the sickest person from getting lungs that could still be done well within ischemic times. And we will want UNOS to sort of look at that, and we are going to advocate for that. But there are extremes, like the Seattle to Miami thing, where it's just impossible for that to occur. Next slide, please. Now, this is the only real complicated graph I have to show you, but I felt it's very important that you see this. It's called the Kaplan-Meier survival curve, and it's from the International Society of Heart and Lung Transplant Registry, which is really our most granular transplant registry, and it is international. And this data is looking between 1990 and 2014, so a long time. What I want you to see is at the top left-hand corner, you see the number 100. And at the bottom, you see 0. So we are going to be plotting survival over time. So at the time of transplant, time 0, we have 100% survival. But as the years go on, we see that the survival starts to decrease. So this is time after lung transplant, and the survival begins to decrease. Now, what I really want you to see is the top line, that purple line. That one represents people with CF who received a transplant. And that line is higher than any other line because the rate of death is slower among people with CF who receive a lung transplant as compared to any other diagnosis that has led to lung transplant. So I know in the community it's often said 50% 5-year survival after lung transplant. The truth is that for people with cystic fibrosis, where you see that purple line crossing that 50% survival mark, is really at about 8.5 years. So in other words, 50% of people with cystic fibrosis are still alive 8.5 years after lung transplant. And what maybe you can even appreciate at the 20-year mark, over 25% of people with CF who've had a lung transplant are still alive 20 years after having received a lung transplant. Now this stands in stark contrast with what the early days, the early 1980s, when people with CF were first transplanted, and we were looking at 40% 1-year survival, as opposed to now 50%, 8.5-year survival. Next slide, please. So the CF Foundation realizes that the transplant journey is arduous, that there's much that can be done to improve not only the journey, but outcomes for people with CF undergoing lung transplant. And therefore, we have made a huge investment and commitment of time and resources. We've made a $15 million investment into improving the lung transplant journey for people with CF. And it's a very comprehensive, multi-pronged attack on lung transplantation. And it includes establishing a collaborative network of clinical transplant centers to improve the care and long-term outcomes of people with CF undergoing transplantation, improving our understanding of the mechanisms of the biggest barrier to successful long-term outcomes in lung transplantation, which is called chronic lung allograft dysfunction. We don't understand why people develop CLAD after lung transplants, and therefore we really don't know how to prevent it, and we don't know how to treat it once it's diagnosed. So we are funding some basic science research to help us understand CLAD. We are also going to empower people with CF by providing support and guidance as they pursue the transplant journey. This will be through our COMPASS program, as well as through community partnerships, where we're all looking to better understand the needs of people with CF pursuing this transplant journey. And lastly, we're going to continue to advocate for people with CF amongst our government, with UNOS, with the FDA, and with third-party payers. Next slide, please. Now, this is a very complicated diagram that there will be a quiz on right after this talk. This actually I stole from Brucey Borowitz, except she had a much simpler honeycomb, and I complicated it. But what I want you to take home from this is simply that we really are approaching the lung transplant initiative from every angle. So not only the science, not only the clinical care, but also advocacy, also improving emotional support and connections for people with CF undergoing this journey, as well as educational materials. We are looking to try and help increase the organ supply, and that we're doing by partnering with an organization called Organize that uses social media to increase donor organ awareness, as well as increasing the ability for people to just say they want to be organ donors, not necessarily on their driver's license, but through social media, and that counts. We've also been in communication with UNOS, letting them know of our concern that the lung allocation score may not accurately predict outcomes for people with cystic fibrosis, and that we really want to look at other variables to help more accurately predict waitlist mortality for people with CF, and also something called ex vivo lung perfusion, which is a circuit that you can take the donor lungs and place them on this circuit and ventilate them and perfuse them and sort of rehabilitate some marginal donors, because not everyone who wants to be an organ donor can necessarily donate their lungs. Sometimes the lungs are too sick to be donated. This EVLP is a very promising technology that may allow us to salvage some of those. Next slide, please. So where are we now? We're very fortunate to have Dr. Joe Paluski, who is a CF and transplant pulmonologist at the University of Pittsburgh, leading our effort and leading our clinical consortium. He's done a wonderful job helping us organize our meeting and our summit and bringing these groups together. We also put out a request for funding applications for, again, basic science research to help us understand chronic lung allograft dysfunction. We received, I was very, very surprised and happy to see over 30 applications, and we reviewed all of them and we funded the 9 best projects. We also have put together a clinical consortium, and we received 16 applications. We reviewed all of those applications, and we funded what I feel are the 10 best. And we're very excited in that representatives from each of those 10 transplant centers will be coming to our national office in Bethesda on April 18th for the very first meeting of this consortium. We've also been pursuing a needs assessment for people with CF to better understand what they need. We're certainly hearing a lot of concerns about revolving around finances as well as revolving around insurance. As I mentioned, we're working with Organize. We've had ongoing discussions, and I'm counting on many more discussions with UNOS and the Thoracic Committee. We have merged the CF patient registry, so our registry, with the UNOS registry, which is called the SRTR registry, to see if that can give us some more immediate information that will help characterize people with cystic fibrosis who are on the wait list and what their outcomes are, to see if we can start to establish or identify best practices so that we can disseminate that amongst the consortium. And we're also working on a palliative care endeavor hand in hand where there is a team of people working on developing CF-specific guidelines and toolkits. And I can see where both the Transplant Initiative and the Palliative Care Initiative at times will help each other. Next slide, please. So, as I mentioned, we're about to meet. We've identified lead candidates because this clinical consortium is going to develop a much more detailed, granular database than we presently have through UNOS or through the ISHLT. We're hoping to really use what we've learned with the CF patient registry, as well as from the CF TDN, and develop a nice registry for transplant patients, as well as the fact that people with who undergo lung transplantation get a lot of procedures done after a lung transplant to monitor the lung allograft, to be sure those lungs are healthy and they're not rejected and they're not infected. And so they get a lot of procedures and they get a lot of blood drawn, they get a lot of bronchoscopies done, and rather than discard any excess samples, we are going to bank those. So we are establishing a biorepository so that we will have this banked, tied into our patient registry, so that when we're ready with study questions, we already have the samples to pursue those study questions. We're going to move forward with CF-specific referral guidelines because we understand that the entire referral process is very confusing. And again, not only to people with cystic fibrosis, but even to our CF centers that don't do transplant. And so we're looking forward to developing referral guidelines that we're going to get out to CF centers fairly quickly. We're also going to develop CF-specific post-transplant guidelines, again, hoping to reduce the variability in care that there is from transplant center to transplant center when we identify best practices. And we're also going to use the proven continuous process improvement methodology, the quality improvement that we've injected and implemented into our CF Care Center network. We want to do that with these 10 consortium sites, and maybe someday throughout the entire transplant world, but for now we'll focus on these 10 sites to address variability where it matters. And what I mean by that, where it affects outcomes. Next slide, please. Oops. So some of the take-home points, again, just to reinforce that lung transplantation certainly has come a long way. But the outcomes, although better than they were 20, 30 years ago, we're not satisfied with them yet. We want better outcomes for people with CF who undergo lung transplantation. And we're joining this journey with you and with them to try and improve those outcomes. We certainly need to improve access to donor lungs. I want everyone in the room to please remember that contraindications to transplant are not punitive. they significantly lessen the chance for a good outcome after transplant. That doesn't mean that transplant centers don't take on those challenges. They do every day. But we need to know that there are some cases where the risk of a poor outcome is just too high, and that's why a certain contraindication may be an absolute contraindication. Half of those transplanted with cystic fibrosis are alive 8 years after transplant. So that's very different than 30 years ago. But still, chronic lung allograft dysfunction is the major limiting factor to successful long-term outcomes, and we hope to try and address that. And the CF Foundation is embarking on this very comprehensive approach to improve the entire lung transplant journey for people with CF. And with that, I thank you. My next slide has all the, I wouldn't be able to present today, and we wouldn't be able to do the work we're doing without everyone on that slide. And I'm open to all your questions. Thank you.
Thank you, Dr. Farrow. So we do have some questions for you. And the first one is, when replacing lungs, isn't a contraindication such as B cenocepacia removed when the old lungs are removed?
That's a great question. So the problem is actually twofold. The first one with any of these organisms is that they infect the entire airway. So that includes the trachea and the upper airway and the sinuses. So even though you take the lungs out that are filled with the cenocepacia, there are still things that are left behind that have cenocepacia that can go ahead and then reinfect the new lungs. And remember, these new lungs are now immunosuppressed. So I didn't really go into the post-transplant field, but after lung transplant, patients have to take medicines to prevent rejection. And these medicines suppress their immune system, so it makes it harder to fight infection. On the second level, transplant in and of itself, as you can imagine, is a very bloody procedure. And it's in fact even bloodier in people with CF because of the chronic infection. There are a lot of what are called adhesions. So the lungs are pretty stuck to the chest wall. And so there's a lot of bleeding when the surgeon is taking those lungs out. So you have two lungs that are filled with these germs, let's say the cenocepacia, and you're pulling these lungs out and there's all this bleeding. There's a decent chance that those germs are going to find their way into the bloodstream. And in point of fact, that's part of the reason why outcomes for people with cenocepacia are so bad, is because they develop blood infections from this germ with the transplant or after transplant.
You mentioned anti-rejection medications, and so I'm going to jump to this question. Do you know if anything is being done to improve anti-rejection medications?
So, unfortunately, there has been no significantly new finding in terms of our armamentarium for rejection in the last 10 to 15 years. And there are lots of different monoclonal antibodies that are very specific to certain things that have been developed in kidney. Very little of it has been looked at lung, and the truth is, even the efficacy in kidney transplantation isn't terrific for many of these. So, no, we need more research done in immunosuppression, and it's not just for people with CF undergoing lung transplant. It's for the entire universe of transplantation.
Somebody asked, you did mention CLAD, and they wanted you to explain that. What is it?
So it stands for chronic lung allograft dysfunction. And the old term that probably people are most familiar with is BOS or BO or OB or bronchiolitis obliterans. And bronchiolitis obliterans is just one form of chronic lung allograft dysfunction. And this occurs, and it's a manifestation of chronic rejection. And it occurs either because of episodes of acute rejection, either because of infections with certain viruses. It's even been associated with acid reflux. In Europe, it's even been associated with pollution. So there are many associated risk factors with developing chronic lung allograft dysfunction after lung transplant. But the easiest way to think about this is it's a manifestation of chronic rejection. An injury has occurred to the airway that the transplanted lung, under immunosuppression, isn't able to address in an appropriate fashion, and instead you get the development of this chronic rejection.
Thank you. We don't have any more questions on online, so I wonder if anybody in the audience has a question they want to ask directly.
Yeah, I attended the first session, then I just walked in here for the question and answer, so I don't know if this was asked and answered already. But I had a question on what the status is of xenotransplants or transplants from, other species to species. And I know there was work being done just 3 years ago with pigs and baboons and using messenger RNA to change the genetics in the donor animal to the same genetics as the recipient animal, and if that's progressing.
And then that work continues. In fact, there was a paper just last week. So that work is certainly continuing. There was actually the paper last week was more focused on ridding the pig lungs from pig viruses, which presents a huge problem for transplantation as well. So the work is still occurring on a very basic science level. I'm afraid unless there are some significant breakthroughs, we're certainly years and years away from that possibility. But it is exciting, and it would certainly increase the availability or pool of organs available to people undergoing transplant, and again, any sort of transplant, not just lung.
And there we go.
Hi, why is it that some transplant centers have reputations as being easier to get listed than others?
So it's probably more focus of what are the contraindications. And so for instance, there really is only one transplant program I'm aware of in the United States that will offer lung transplant to people with CF who are chronically infected with Burkholderia senocepacia. So that's the only program in the country that is willing to evaluate and pursue transplant for people chronically infected with that germ. And so there may be a sense that, that program is easier. But in reality, it's that they're willing to take on the risk. They feel they have appropriate protocols in place. And they're trying to learn from it. And I think that's really the approach. I think the approach we need to take for some of these absolute contraindications is allow a few programs who do this under research protocols. So they really are learning from doing this procedure how to improve and how to make these outcomes significantly better. As I mentioned, I hopefully mentioned during this talk, 1 year survival for people undergoing transplant with senocepacia is only 40%, and that's 1 year. And so we need to make that better. And supporting, if the transplant network in our country would support some of that research component to this, sort of like in the cancer world where they embrace protocols. So if you have a cancer, you are most likely to end up on an oncology protocol where there's a study ongoing. And that's why there's been so much improvement. I mean, in terms of when you think about childhood cancers and the improvements that have been made in outcomes for childhood cancers, it was all because that there were these study protocols that were being run one after another, allowing for that improvement. And in my opinion, that's something that we should be doing. But I'm not sure if the perception of easier is really just based on the fact that there's a center that's okay with one certain contraindication that another center isn't, but then another center may be okay with a certain contraindication that another center isn't. So again, there's a lot of variability in there.
We're just about out of time, but if we had one more question. I don't see any more questions. Thank you, Dr. Farrow. Thank you. This was an excellent presentation.